We have reached the hour, and I'd like to welcome everyone to today's webinar, Best of ASH 2021. I'm Brian Durie, Chairman of the Board for the International Myeloma Foundation, and very pleased to have this opportunity to present this exciting information from this year's American Society of Hematology meeting, and glad that so many of you have set aside the time to join us today. And so, if we can get the slides activated here, which I think we have, yes. First of all, I'd just like to thank our sponsors who really help us to do so many things: Amgen Oncology, Bristol Myers Squibb, Janssen Oncology, Karyopharm, Oncopeptides, and Takeda Oncology. And so, this year's ASH 2021, American Society of Hematology, the 63rd year of this meeting, was a virtual live hybrid. And in a moment, I'll show what that looks like in real life. How exactly does that work? But certainly a very difficult and different meeting for everyone. But nonetheless, there were 879 myeloma-related abstracts, and many with quite important information for the myeloma community. I would say that it was an unusual combination of abstracts this year in that I think for the first time in my memory, at least, the major abstracts did not relate to the results of some new treatment, but addressed questions about the onset of the disease, the early evolution of the disease, and the biology and diagnostics. And so I'm going to focus on that because this was an unusual and important aspect of this year's ASH. And so just to show you a little bit about how things worked, on the Friday, which was this past Friday, the International Myeloma Foundation holds a satellite symposium on the Friday afternoon. And normally we have between 800 and 1,000 participants in the room. In the pictures on the slide here on the top left, you will see the 211 people who were there live having their lunch before the start of the meeting. But you'll see over on the right, there were in the middle, you'll see 647 people joined virtually. And so the total attendance turned out to be very close to what we normally achieve, between 800 and 1,000 people. And on the screen on the right, you'll see that Philippe Moreau, Jesus San Miguel, and myself, we participated virtually and in person. At the bottom, you'll see Dr. Tom Morton and Vincent Rajkumar, who were there for this program, adapting clinical practice to a rapidly changing therapeutic landscape in myeloma, which is a case-based approach. And you'll see on the bottom right that this is already available for replay. And so you'll see at the bottom right of a lot of the slides, we have these red links that you can take advantage of. And so the next morning, first thing in the morning, on the Saturday, we have the International Myeloma Working Group breakfast, which starts at 6:30 in the morning, incredibly early. And so even at that hour, and you can see on the left, there were 120 of our myeloma experts from around the world who were able to participate live. 230 participated virtually, so giving a total of 350 people, which is just a huge turnout for this meeting. And very pleased to see that. For me, this was a meeting which started at 3:30 in the morning, Los Angeles time. So there were a number of challenges with this year's ASH. Down on the bottom, you'll see Dr. Tom Martin, who presented his results with the Cartitude T-cell data at the breakfast. A key and very, very important part of the IMWG breakfast is that we preview the ASH abstracts. So we select what we think are some of the most important abstracts and present them to this group. And it turns out that with 350 participants, this was possibly the largest audience that the presenters had during the whole meeting, because some of the live meetings were unfortunately rather sparse. So, what were the top abstracts this year? Well, it was really quite surprising and amazing that the iStopMM project, Iceland Screens, Treats, or Prevents Multiple Myeloma, had the top abstracts at ASH this year. Now, for full disclosure, I'm actually a co-author on these abstracts, and so I'm personally involved with these. And the team submitted 6 abstracts to ASH, and I can tell you that when the results came in, we heard that one of our presentations had been accepted as an oral presentation, and we were quite excited about that. But as the morning wore on, we got another email that a second abstract was accepted, then a third, and then a fourth. And then it kept on going. We also had 2 that were accepted as poster presentations on different aspects of this project. And so just amazing that this was such a priority for ASH this year. And so the team who is working on this is led by Dr. Sigurdur Christensen, who is in the purple circle there. And you can see this is a very happy and active team, which is something that you need to make a project like this move forward. And this is at the Decode Genetic Buildings at the University of Iceland. And so there are just so many diverse outcomes that can come from this iStopMM program. You can look at so many different things once you have identified individuals who do have a monoclonal protein in their serum. And so let me explain what this project is all about. The idea is to look at the population of Iceland. And so everyone in Iceland over the age of 40 was invited to participate in this iStopMM project. And over half of them agreed to participate. And that meant that they would sign up a consent form to agree to move forward if their blood sample happened to show a monoclonal protein in the blood. And so there was a screening process, and it was very, very fortunate that the binding site company based in Birmingham, England, was willing to run the screening samples, including with mass spectrometry. And so they screened the samples, and individuals were identified as having MGUS, and then they were randomized into 3 groups. And this is extremely important. One group where there was nothing further to be done, arm 2 where normal intermittent follow-up was provided, but also arm 3 where a lot of additional testing was carried out, including bone marrow testing, whole body low-dose CT, plus additional blood and other testing, including psychological evaluation, because we wanted to find out if there was a negative psychological impact on individuals if they found out of the blue, really, that they had a monoclonal protein in their blood. And so what happened? Well, it turns out that over 75,000 individuals in Iceland had their blood tested, and out of those, 3,725 were found to have a monoclonal protein present in their serum. And those were randomized into the 3 different groups that you see here, balanced. So what happened? Well, the reason that the data were submitted to ASH this year is illustrated on this slide here. And so on the left, where the patients were not further evaluated, there were no new findings or diagnoses. With routine monitoring in the middle, you can see that some patients were found to have either smoldering myeloma, SMM, which is the green box, or myeloma, the blue box at the top. But over on the right, you can see that with more detailed evaluation, that even more individuals were found to have smoldering myeloma and even active myeloma. So this is amazing. People who were just going about their daily life were actually discovered to be in the process of developing active myeloma, and a very large number were found to have smoldering myeloma. And this was the basis for one of the abstracts. And so an unexpectedly high occurrence, prevalence of smoldering myeloma. This was a full abstract on this particular aspect. And you can see here that in total, 180 individuals were diagnosed with smoldering myeloma out of the blue. And so the full details of those individuals are under analysis. But you can see this related to bone marrow testing that was carried out in over 1,500 people. And now there was a concern that individuals might be anxious about having a bone marrow test performed, but it turned out that actually the people who were randomized to not have a bone marrow sampling, some of them got upset because they felt like they wanted to have their bone marrow tested as well. And so there was just a tremendous enthusiasm in the participants to really participate in this particular aspect of the project. And so if this was tracked out over the age spectrum, it turned out that half a percentage point of people over the age of 40 actually had smoldering myeloma. And so this does really raise the question of whether it really is appropriate to screen and try to identify these individuals early with the option of potential early intervention, which I'll be talking about in a minute. You'll notice at the bottom of this slide, we do give you the ASH abstract. We also have a video summary with the author. Now, what was particularly important in one of the abstracts was the testing for COVID-19 in all of these MGUS patients and comparison with the rest of Iceland. And in figure A and figure B, you'll see that there are two lines, the violet one and then a greenish one, but they run in parallel, which indicates that throughout the age spectrum, there is no increased occurrence of COVID-19 in MGUS patients versus the rest of the population. And so, although there is a concern that as myeloma evolves, there is immune compromise which develops, and this certainly does happen, and we'll talk about that later. At the early stages, it appears that this immune compromise does not predispose individuals to more issues with COVID-19, which I think is really rather good news. Okay, so let me just stop there for a moment and just say that this is a very capsule summary of these abstracts from Iceland, and the takeaway which has been occurring in these last few days is that this has really had an impact on everyone who's hearing this information and raising the open question for discussion now, should we be screening for MGUS, and what does that look like? Well, the randomized piece of this trial will be broken in this coming year, and at that point, it will be possible to look at all of the outcomes and help to make a decision about the value of potential screening for MGUS. Now, a separate team from the University of Navarra in Pamplona in Spain did a very large study looking at patients with MGUS using flow cytometry immune testing to see if they could identify individuals who had stable MGUS versus smoldering or progression to even active myeloma. And so what they found was that by screening over 5,000 patients using the flow cytometer, they were able to identify individuals who had what we would call stable MGUS. In other words, they had a low level of protein, but they were at very, very low risk in what they call the training data set zero progression within the first 5 years. But you'll see in the other sets, there was a 50-60% risk of progression, and that was not so easily predicted. And so this was extremely helpful in identifying individuals with stable MGUS using the NGF, Next Generation Flow Immune Testing Protocol with the flow cytometer. But I think what was possibly more important and more interesting was, what about the patients with smoldering myeloma or early myeloma? And this separate study, which was abstract number 76, the number of circulating tumor cells. So this is actually circulating plasma cells, but they're called CTCs. These were measured again using this specialized flow cytometer. And it turned out that you can be very precise about the level of these cells, and 0.02%, if you have more than that, so that might seem like a pretty low number, but this can be measured very, very accurately using this automated machine technology. And so if you do have 0.02% plasma cells in the blood or more, then there's a very high risk. It falls into what we call ultra high risk of movement into myeloma within less than a year. And so you may be aware that for high risk smoldering myeloma, we currently use what we call the 2-20-20 model. So 2 grams of protein, 20 for the free light ratio, and 20 for the percent of plasma cells in the bone marrow. So what the Spanish team did is that they substituted the 0.02% in the blood for the 20% in the bone marrow, and they discovered that this gave an even better predictive model. And so now we're working towards proposing a new model for high-risk smoldering, which would be the 2-20.02. And this has 2 advantages. One, it looks like it is going to be more accurate. Plus, it means that instead of repeating bone marrow testing to see if the bone marrow percentage is 20% or less or more, the sample can be checked in the blood. And so this is something very promising for now and in the future. And so this is the team from the University of Navarra, Dr. Bruno Paiva, the young gentleman who has been so active in research, and the senior investigator, Professor Jesus San Miguel, who has led this amazing team. Now, another important abstract on MGUS was presented from the PROMISE study, which is a study in Black African-American patients, and 296 individuals were tested here with that same cutoff over 40 years. So we use that as a cutoff because the likelihood of a monoclonal protein goes up after the age of 40. Now, in this particular study, they evaluated people who would be considered to be at a little bit higher risk because they had a family history of MGUS or myeloma or some type of a related problem. And in this sort of higher risk population, they found an occurrence of 10% who actually had a monoclonal protein. And they validated that using biobank samples from African Americans in a separate biobank study, so that they were able to show that this was consistent with their new findings. So very important. And then this also raises the issue that screening could be something very helpful to be performed. Now, one of the reasons for being interested in identifying MGUS and identifying smoldering myeloma, particularly high-risk smoldering myeloma, is that early intervention can be offered. And so the CSER trial is a trial for patients with high-risk smoldering myeloma using the 2-20-20 criteria, the older model. And in this particular trial conducted by Mary V. Mateos at the University of Salamanca, patients received Kyprolis, Revlimid, and dexamethasone, followed by autologous stem cell transplant. 90 patients were included in this pilot study, which has been running for close to 5 years now. And so we now have follow-up at 55 months, and you can see the two blue lines on the left. You can see the length of the remission, the progression-free survival. 94% of the patients are still in remission at this point. And you can see the overall survival, 95%. And the remissions are really deep and excellent, with 67% of the patients having MRD negative at the 12-month follow-up time point. So these are really very, very promising as a decisive way to provide excellent early intervention in high-risk smoldering myeloma. This is part of the Black Swan Cure project, and we also have the ASCENT trial, which was not presented at ASH this year yet. Now, in evaluating response, in addition to the normal techniques, we have been using next generation flow, but also mass spectrometry, which I've mentioned a couple of times. And so in another analysis, follow-up of the remission status was evaluated using mass spectrometry in the blood, as well as next generation flow in the bone marrow. And what turned out is that if using the very, very sensitive mass spectrometry method, which looks for the myeloma protein in the blood, if that was negative, that indicated that patients would stay in remission longer, PFS longer, the red lines. And in a very, very similar fashion to using next generation flow in the bone marrow. And so it seems that these two techniques are definitely complementary. And there was a lot more information presented. There are some patients who are, for example, NGF negative, but positive using the mass spec extent method. And so these are patients that may have a very, very low level of disease, and we need to understand those patients a little better. Now, moving forward into some of the very important treatment results that were presented at ASH this year. Abstract number 79, the results of the Griffin trial. And this has been presented a few times, actually, but it was represented because there was an updated analysis after 24 months of maintenance. And so in this study, half of their patients received daratumumab plus lenalidomide, bortezomib, and dex. So dara, RVD, and then the rest of the patients receive just the RVD. And so it's a comparison of 4 drugs versus 3 drugs. And this has been a very topical question, what we call a quad versus a triplet. And so the question is it worthwhile to give that extra 4th drug, in this case, the daratumumab, as a first step? So for the first time at ASH, we saw the remission, the PFS data, where after that 24 months of maintenance, PFS was evaluated at the 3-year time point. And you can see 88.9% versus 81.2%, which is statistically significant. So you can see for the first time that there is a trend to having a benefit using the 4 drugs versus the 3 drugs as a first step. Now, this is a very important point, and there are a lot of issues in terms of, is this the way to go? What about the toxicities? What about the costs? And so this is really triggering a very active discussion about the pros and cons of 4 drugs versus 3 drugs. Now, additional information was presented looking at the achievement of an MRD negative status. And you can see on the left, the purple is the 4 drugs. So purple is RVD, DARA RVD, and then the orange over on the right is the RVD, just the 3 drugs. And so the first thing you can see is that the purple bars are much larger than the orange bars. So you can see for sure that there was more MRD negativity with the 4 drugs versus the 3 drugs. Now, if you look more carefully, you see that with time, the height of the bars goes up. And so at this 2-year maintenance time point, you can see with the 4 drugs, 64% have MRD negative at 10 to the minus 5, and 36% have a negative at 10 to the minus 6, 0 out of a million. And you can see that with the RVD is basically about half of that. And so a significant added benefit in terms of achieving deep response with the 4 drugs versus the 3 drugs. And that this is increasing or improving throughout the maintenance. And so this really predicts for a better outcome. Now, there were also early data presented at ASH using isatuximab, which is the alternate anti-CD38 monoclonal antibody. So both daratumumab and isatuximab, those are both monoclonal antibodies against CD38 on the surface of the myeloma. And so in this case, isatuximab VRD was compared with VRD by Dr. Hartmut Goldschmidt and his team with this German HD7 trial. And in this case, it's early data, but again, there's a similar trend with more MRD negativity after induction with the 4 drug versus the 3 drugs. So much more to come on that. And you'll see that there is a video summary available with Dr. Hartmut Goldschmidt. Now, another study was presented looking at the maintenance setting, and in this case, the oral proteasome inhibitor ixazomib, also known as Ninlaro, was compared as a 3-drug combo versus the 2-drug Revdex. And excellent results were seen with both 63 and 62% of the patients staying in remission at the 5-year time point. So really both groups doing well. There are other parts to this study where the addition of the ixazomib did increase the number of patients with MRD negativity. So more to follow on this particular trial, but at 5 years, 63% and 62%. Now, for the balance of the presentation today, I'm going to focus on the relapse situation and the difficult situation that emerges for many patients with myeloma these days, which is called triple class refractory. And so this refers to patients who have received an IMiD. That means that they've received Revlimid or pomalidomide, that they have received a proteasome inhibitor. That means Velcade, Kyprolis, or ixazomib, which I just was talking about. And then the third group would be daratumumab or isatuximab. So refractory to those 3 types of drugs. And so we're seeing, obviously, and many of you may be experiencing this, where you have received all of those and the myeloma is active again. And the question is, what are the options to be considered? And several of these were the basis for presentations at ASH this year. So over on the left, you have agents which are commercially available, they're approved and can be used in this setting. So those are the blue on the left. I'll just touch on a couple of things there. In the chemotherapy column, you'll see in the middle cyclophosphamide, which is also called Cytoxan, as well as melphalan. And so I'd just like to point out we should not forget about those, and particularly melphalan now, since we did have a new form of melphalan that was available called melflufen, but this was unfortunately withdrawn by the FDA just in these past few months. And so we should still, since we don't have that available anymore, we should not forget about melphalan. And so then I'll talk a little bit about selinexor and dex, Celidex, which is approved, and then venetoclax, and the data for that were updated at ASH. The Bellini trial, basically indicating that, again, we see benefit in patients who have the 11-14 translocation, but not broadly in the myeloma population. So the overall survival in the Bellini trial did not show benefit, which has slowed the development of this particular drug. Then in the orange and the green, I'll take some time to discuss several of these immune therapies, of which belantamab and ide-cel, the CAR T product, both of those are already approved. So with regard to selinexor, there was an interesting data set presented where selinexor was more favorable for patients after daratumumab treatment. So this is obviously quite useful and very interesting, and it had a basis in some detailed lab testing. So quite an interesting new piece of data related to a niche use or clinical area of benefit for selinexor dexamethasone. Now, we also had some new data on belantamab. This is the monoclonal antibody against BCMA, B-cell maturation antigen. So we talk about that a lot. BCMA, which is very widely expressed on the surface of the myeloma cells. And so belantamab targets that, but it also is linked to a drug conjugate, and works well by itself. In this new study, DREAM9, presented at ASH, it was combined with BRD in the frontline setting. So really a unique trial. And the data are very early, but as you might expect, results are quite good. There was also data on a DREAM5 update where the belantamab was combined with something completely new, inducible T-cell co-stimulator agonist, quite a mouthful, AICOS, they call it for short. Anyway, a little confusing, but this is a synergistic combination, and so there's a bit of interest in that to see if that could be a good combination. Now, another new agent that was presented at ASH this year is TAC573, which is called an immunocytokine. It's kind of a new type of a molecule, and phase 1 in human trial, and promising results. Overall, about a 30% response rate, ORR 38%, 20% in patients who had BCMA types of therapy, but quite promising for a single agent. So we will be waiting to see more follow-up with that. Now, as far as the bispecific monoclonal antibodies, now these are antibodies which target the myeloma, but bring in the T cells. So they have two targets. They bring the T cells in to more efficiently target the myeloma. Now, some of these target BCMA, but one new one called talquetamab targets another surface receptor, GPRC5D, and a combination with DARA was used in one trial, and a single agent trial was also presented. So this is a relatively new bispecific with promising combination data and single agent data. So people are watching that closely. And as you'll see, it's important to be aware because these agents have significant responses in this relapse refractory setting. And so if trials are available, these can provide significant benefit for patients. And so another one which falls into that category, a new bispecific, in this case, it's BCMA versus, plus the T cells, and it's from the Regeneron company, REGN 5458. And again, we have promising data with responses increasing as you go from left to right. The height of the bars go up to 75% ORR with the higher doses. And you can see on the right, as you get to the blue, in this case, you're getting to stringent CR. So you can see that patients are having significant responses, and some of them are reaching those deep stringent CR levels. So people are excited about this new agent. And so overall, we need to look at where are we with the bispecifics. And you can see that there are several that target this BCMA, the B-cell maturation antigen, and then a couple that have these new targets. I'd point out two things. One is that the response rates are really quite high for the BCMA targeted agents in the 60 to even 80% range. And so very important for patients looking for new treatment options. And the risk of cytokine release syndrome, the toxicity that can happen, very rare to have this be a major problem. Now, these agents can be given IV or sub-Q. The sub-Q dosing is obviously more convenient, and you'll see over on the right that teclistamab, which is probably the furthest along and maybe the most likely to be first approved, there is subcutaneous dosing for that, as well as our antamab subcutaneous dosing, and also for the talquetamab, which I touched on a minute ago. So a lot of excitement with the emerging data with these bispecific antibodies. But I would say that perhaps the most striking and a little bit surprising results came from the longer-term follow-up with the CARTITUDE-1 study presented by Dr. Tom Martin. And so this is a CAR-T directed against this BCMA. And this is obviously a technology where the T cells are taken from the blood of the patient. They are engineered in the lab to attack the BCMA, and then they're given back like a blood transfusion 3-4 weeks later. And so it's what's called a one and done. So it's a one-time infusion that attacks the myeloma, and the results have been remarkably good. So the response data, look at these numbers. The overall response data, 97.9%. Very, very high response rates. And you can see that most of these were very deep responses, 82.5% stringent CRs. Now, if you look at the boxes over to your right, this has been tracked over time. And you can see after a median of 1 year, 67% had stringent CR, but then after 2 years, 83%. And so the responses are getting deeper over time, even although there is just that initial treatment that is given. And so this has been quite interesting and surprising that patients are doing remarkably well with this treatment. And so if we look at the progression-free survival and the overall survival, patients doing really, really well. And keeping in mind that these are patients with very advanced disease, relapse refractory disease, who are having these sustained remissions out over 2 years and a significant overall survival at 2 years also. So really excellent results. Now, this is a data set which has been submitted to the FDA, and everyone is looking anxiously to the first or second quarter of next year to see if the FDA will look favorably on these data, and we would then have the approval of a second CAR-T product, what's called CytoCell. And just to show you that the MRD negativity rate is also very, very high, and the subset of patients who have that MRD negativity have more sustained remissions at 2 years, all the way out to 3 years, and obviously excellent survival. And so the big discussion right now is what are the advantages of the belantamab, which is the antibody drug conjugate, the CAR T cells and the bispecifics, And there are a number of pros and cons, and you will have these slides and you'll be able to take a look at it. I would just emphasize a couple of things. One is that the CAR T cells, it's a single infusion, one and done. However, it does require the manufacturing, and that is done only at a limited number of centers. Not every center is going to be able to do that. The bispecifics are off the shelf, so this is something that's available everywhere, and the same is true for the belantamab. So a couple of key differences right there. One last drug I'd like to mention is what's called the CELMoD class of drugs, and this is similar to Revlimid and pomalidomide, but importantly different, with slightly different mechanisms of action, and they're called CELMoDs. And one of those is called iberdomide, which is like Revlimid and pomalidomide given along with dexamethasone. And you can see here that the response rates are in the 25–26% range, and so respectable. But I have to say, when we've just come from CAR T with a 97% response rate, these responses are important, but certainly modest. And so we look at the future with the possibility of combinations with that. For COVID-19, there were quite a number of abstracts on that. Not really much new, and everyone is obviously anxious about what will be the impact of our new Omicron variant, and maybe I'll leave that for our upcoming discussion. And then just so that you have them for your files, as part of our satellite symposium, we do what we call these algorithms, where we outline what is the strategy at each different stage of the disease. And so right at the beginning, if you've got myeloma, start treatment. If you have smoldering myeloma, you assess if it's high risk and decide to perhaps consider treatment or go into a clinical trial. Then for the newly diagnosed, for the non-transplant candidate, now we have two major options: Revdex plus D, which is daratumumab, or V, which is Velcade. In Europe, some other combinations can be used. For transplant candidates, the big question, which I've touched on, is VRD plus or minus daratumumab. And we still are looking to include autologous stem cell transplant, although I would have to say, looking to the future, with the data on CAR T cells, people are talking about, well, maybe instead of an autologous stem cell transplant, we should be thinking of using these amazing CAR T cells earlier in the disease as a consolidation approach. And so a lot of interest in thinking in that way. And then in the relapse setting, the big thing is whether a patient has failed, or the patient doesn't fail, but how they have become refractory to lenalidomide or not, and then looking at different combinations as a backup, using, for example, pomalidomide if you're refractory to lenalidomide, and bringing in Kyprolis and daratumumab. If you're refractory to daratumumab, Pomdex plus Elo, KPD, you can see several options there to be thinking about. And then for the higher levels of relapse, certainly CAR T, the belantamab, selinexor, chemotherapy combinations. There is still the option of panabinostat in some parts of the world, although it was withdrawn in the United States by the FDA. Venetoclax is commercially available and can be considered, but only for patients with the 11-14. And of course, Cytoxan, cyclophosphamide can be considered. Okay, so I've given you a crash course on ASH 2021. And I'm very happy to try to work through some of the questions that have been coming in. And so I can see that quite a few are sitting there already. And so what I'll do is just to try to cycle through those and cover them as best that I can. Yes. So first question is about maintenance. And for now, maintenance for a standard risk patient, Revlimid is really the recommended choice. We use a combination with a proteasome inhibitor. It's preferred if there's a high risk cytogenetic findings. But this patient is saying standard risk. No, I think a lot of people have been having this next question, which is recommendation as to how soon after the third shot should a patient be boosted again. And so this is something that is just being discussed at this point. And so the first point is that the data are clear that if you've had 2 doses of the Pfizer or the Moderna, that third booster shot is strongly recommended and it really enhances the antibody levels, even for patients with myeloma who are on treatment. However, there is a concern, particularly with the Omicron variant, that it would be good to get the levels boosted as high as possible. Now, we don't have data on that, and this is for open discussion right now, but I would think in the 2 to 3 month time frame after a third shot, this is something that could be discussed to try to boost the antibody levels. But checking the antibody levels is possible now. And so in this scenario, for the time being, until we have more data, I would recommend that you talk to your doctor and arrange to get antibody testing levels checked if possible. So for smoldering myeloma, are there any updates on what is the standard of care? I think that the standard of care for the high-risk smoldering is to consider some form of treatment. And I think that there was a lot of discussion, and I'd recommend listening to our satellite symposium, where we actually had excellent input from the panelists on the pros and cons of using just lenalidomide, Revlimid versus myeloma treatment versus more of a cure trial option like the KRD transplant to really have a decisive benefit. I would say that my personal recommendation is to consider more of a myeloma type therapy, which would be a triplet or even a triplet plus transplant if there really is a high risk myeloma situation, because we know that if we just continue to watch, problems can emerge. What alternatives to Revlimid are being studied for maintenance? Well, certainly Ninlaro is being looked at, and then there are ideas about using for the future one of the cell mods, for example, pomalidomide. Obviously, depending on the protocol, we do use different types of maintenance, so that, for example, if a patient has relapsed, daratumumab, pomalidomide, and dex is used, and then we would use pomalidomide plus dara as maintenance. If dara Revlimid has been used for induction in a non-transplant patient, we would often continue with dara plus Revlimid as a maintenance option, and that is the Maya regimen and has been one of the most successful regimens, actually, with the initial remission duration in excess of 50 months. So very, very good results with that. For localized breast amyloidosis, nothing new that I'm aware of, although I would just say that most of the treatments that we use for myeloma do seem to work quite well in amyloidosis also. So daratumumab, and I would think that potentially some of the newer immune therapy options to be considered. So I'm just trying to skip through and see if I can find yeah, hold on. How many total cycles of RVD are recommended in standard risk transplant. Right. So I think that how do you decide? Yes, I think that this is obviously a personal decision. It's definitely based upon the depth of the response. And so if you've achieved a CR and perhaps even MRD negative, it would be reasonable to shift to Revlimid maintenance. So that if you achieve that at 8 cycles, it would be very reasonable to go to Revlimid maintenance at that point. Is the number of confirmed myeloma cases in the United States increasing? Yes, it's increasing annually, and this has been a significant change in the last decade to 15 years, and we don't really understand why, but in most of the sort of westernized world, the number of myeloma cases is definitely continuing to increase, and so we do kind of assume that it's linked to some aspects of urbanization. And as part of the Iceland project, the iStopMM, we are obviously identifying patients very, very early in their disease course when they have a tiny monoclonal protein. And so we are carefully, one of the many outcomes of the Iceland project is that we have the opportunity now to study patients with extremely, extremely early monoclonal proteins to figure out what may have been trigger factors. So we're looking at infection as trigger factors. We're looking at immune issues. We're looking at a variety of things to see if we can identify what would be important trigger factors for early disease. We've already noted that very early, some patients will develop monoclonal spikes, which actually disappear over 3 to 6 months. So we know already that it can actually be a temporary phenomenon for some patients, and then it stabilizes for a majority, and then we need to identify what triggers it to move forward from there. Why is so much made out of 4 drugs versus 3 drugs when DARA by itself works so well? This is a good point, but actually DARA does work well by itself, but the combination, now it doesn't need to be a 4-drug combination with DARA, and this is a very important question, is that DARA plus Revlimid and Dex, that's the Maya regimen, is one of the best combinations that we have. So a 3-drug combination, very, very good in terms of first remission and overall survival. And so this is a good point, but DARA in combination with RevDex is definitely better than just DARA by itself, which is excellent, but improved with the addition of RevDex. What do I think about maintenance after CAR T? Well, I would say that this is being looked at by a number of groups, but as I showed you, a number of patients do achieve deep, deep responses, stringent CR in 83%, MRD negative in 60, 70%, 64%, I think it was. So these patients have a big advantage that they have these fantastic responses and they don't need to be on any treatment. I suspect there may be some patients who receive CAR T on this webinar today. And one of the big advantages is that they continue to do well, feel well, function well, and they're not on any treatment. And so I think that, yes, we need to look at combinations and maintenance, perhaps for patients who have not had MRD negative. But one of the big advantages is to have an approach that will get you to that MRD negative, and we don't need maintenance. And this, again, is quite important related to COVID-19, because this means that in the 1 to 2 years after a CAR T treatment, if the patient is off maintenance, their immune system can recover, and then they're in better shape to fight off COVID-19. And so there are a number of advantages to have a decisive treatment and then have a recovery of the immune system. This actually is one of the sort of side issues with the bispecific therapies, because that is an ongoing therapy. That's an ongoing therapy. And so then you have ongoing suppression of the immune system, even although it's working well. Okay, something different. In the middle of RVD, should we ask his doctor to start a 4-drug regimen? Right. So as they say, changing horses in midstream is never a good idea. If you're doing well and you achieve an excellent response with a 3-drug regimen, that is fine. One of the things that we've learned in the last 10 years is that whatever the treatment is, if it's gotten to you to have a stringent CR or MRD negative, that is the most important thing. And that's excellent. And then you can save that 4th drug for later. Does MRD refer to next generation tests? Sure. So minimal residual disease. I'm sorry that I didn't maybe clarify that completely. So minimal residual disease is a reference to a bone marrow test, and the bone marrow can be tested by sequencing or by flow. And in some recent comparative studies, the results of that give equivalent information. And so if you're negative with one, that information is equivalent to being negative with the other one. And so whatever might happen to have been available, this is a good test to have. Did the slide on Griffin study show the original treatment or was it the post-transplant maintenance treatment? The data are segmented based upon the original treatment plan. So that is correct. So the outcome is looked at. Now they had some options, but the segmentation is based upon, did the patient receive 4 drugs or 3 drugs at the outset? The CT serum test is still under study, not generally available. That is correct. However, this is a good question because the flow cytometer that is necessary to do this testing is widely available. And so, for example, I think it might be possible to send samples to the Mayo Clinic, for example, and get this test done. But within the next 6 to 12 months, this is sufficiently important that we are looking to try to structure this so that this test can become more generally available. Obviously, it is important that it is done accurately and in a standardized fashion. And so we need to make sure that protocols are in place where one of the techniques is what's called automatic gating. So as the cells go through the machine, they're handled in an automatic way. And so it needs to be done in an accurate way, but we are hopeful, and we have some examples where Euroflow, the group in Europe, have set up protocols across Europe where this can in fact be done in a standardized fashion, and you can get the results as a clinical tool. Yes, the MRD negative actually improved over time. Yeah, this is correct. Yes. Obviously, in the Griffin trial, there was ongoing maintenance, and it did improve over time. Yes, you're correct. Can I explain the significance of? Yeah, so that this is a question about deletion 17. Yeah, so P17. So this means that part of the chromosome, the top part of chromosome 17, is deleted, and this is what's called a high risk chromosome finding. And so this means that the doctor needs to be aware, and you need to be aware that the treatment could work, but for maintenance, we should be looking at not just Revlimid, but maybe a proteasome inhibitor, perhaps like Velcade. So this is what we call a higher risk myeloma. So something to discuss carefully with your doctor. And so we're getting close to the witching hour here. And so I'm not sure if I can cover too many others here, but we can certainly try to get back to people with answers to some of those that I haven't been able to get to right now. But since we are at the hour and people I know have busy lives, we don't want to go beyond our time. So I'd like to just close by again thanking our sponsors, Amgen, Bristol Myers Squibb, Janssen Oncology, Karyopharm, Oncopeptides, and Takeda Oncology. We always appreciate their support. And so thanks to you all. I hope that this was an informative and useful session. I certainly tried to give you the essence of what the very unique hybrid ASH experience was this year, which I experienced in a virtual fashion, but was really quite important. So thank you all.